Kidney Day and International Women's Day. Ma'am?
Go on.
I immensely thank you all for taking the time to join us on this pleasant Sunday evening. I am Dr. Kirti, consultant nephrologist at Sri Balaji Kidney Care Center, Nandyal. This evening's webinar is packed with talks reminding us of our social responsibility and civic duty. You must all be excited about the International Women's Day and the World Kidney Day coming in 3 to 4 days. We have talks in this webinar on these two themes. As this is going to be an exciting non-academic session, sit back, relax, and let's get started. I take the honor to invite a highly respected figure in the field of nephrology, Dr. Hitaishi ma'am, to talk on the various activities planned on the eve of World Kidney Day.
No, Dr. Jikki is there. She is present.
Okay, without wasting much time. Anyway, Hitaishi, very kind of you to have accepted in case of my absence. Good evening to all of you.
Good evening.
I feel very much privileged to present the 20-day activities of the WKD celebrations of the WIN AP chapter. And I also thank our APS and other members, the men in nephrology who have joined to support us. Today, I think all of you know about the activity today. So tomorrow, that is on 6th, there is an essay competition for the PGs in medicine, the topic being ECA in pregnancy. And for PGs of nephrology, artificial intelligence in nephrology, with attractive prizes being announced. Then on 7th, we have a CME in the pediatric topics of steroid sensitive, steroid resistant nephrotic syndrome and vesico-ureteric reflux. It is between 6 to 7:30 p.m. with very eminent speakers and chairpersons. On 8th, there is a kidney quiz for the PGs in nephrology. And on the eve of the International Women's Day, the celebrations will take place at the local places by the respective individuals. Then on 9th, the actual WKD, there will be rallies, walkathons, free camps, all India radio talk and television interviews by the local nephrologists, and to create public awareness on kidney diseases. And to top all of these, this year, under the aegis of the AP Society of Nephrology, we have planned a media handle which is titled Kidney Dialogues. It is like an answer to the common questions posted by the public, patients, and the press or the other media. And it involves almost every nephrologist in AP in some way or other. And with this, I conclude and thank you all for joining us here for the feast that is ahead. Thank you, Katie.
Thank you, ma'am. Thank you, ma'am. The next talk is on the theme of World Kidney Day 2023. To chair the session, I invite Dr. A.K. Chakravarti, consultant and chief nephrologist, Apollo Hospitals, Nellore, and Dr. Manjusha ma'am, professor, head Department of Nephrology, Gandhi Medical College, Hyderabad. Over to the chairperson.
Good evening, everyone. First of all, let me thank WIN for inviting me as a chairperson for this important session, celebrating the World Kidney Day of 2023. And as we always know that prevention is better than cure, I think it is very much apt that this year theme is identified as preparing for the unexpected and supporting the vulnerable. This gains more importance, especially after the recent COVID epidemic, where we saw a lot of morbidity and mortality in our kidney patients. So today, Dr. Sindhu Chaganti will enlighten us how we nephrologists should be prepared to face unexpected problems in our kidney patients. Over to you, Dr. Sindhu.
Good evening, everyone. Is my screen visible? Is my screen visible?
Yes, ma'am. Yes, ma'am.
Okay. Today I'll be talking about kidney health for all, preparing for the unexpected and supporting the vulnerable, this year's kidney theme, World Kidney Theme. I'm Dr. Sindhu Chaganti, Assistant Professor of Nephrology, Dr. Pinnamneni Siddhartha Institute of Medical Sciences, Gannavaram, Vijayawada. A brief history of World Kidney Day. The International Society of Nephrology and International Federation of Kidney Foundations collaborated to create World Kidney Day. It helps in broadcasting the importance of kidneys in our overall health and reducing the frequency of kidney diseases worldwide. A brief history of last 5-year World Kidney themes. In 2017, the theme was Kidney Disease and Obesity, Healthy Lifestyle for Healthy Kidneys. 2018, Kidney Disease and Women's Health, Include, Value and Empower. In 2019, Kidney Health for Everyone, Everywhere. 2020, Kidney Health for Everyone, Everywhere, from prevention to detection and equitable access to care. 2021, Kidney Health for Everyone, Everywhere, again, with living well with kidney disease. And 2022, Kidney Health for All, bridge the knowledge gap to better kidney care. Again in 2020-23, Kidney Health for All, but this time preparing for the unexpected and supporting the vulnerable. Coming to the impact of disastrous events, these disastrous events affects functioning and living conditions of the community as a whole, leading to drastic consequences like human loss, material loss, as well as economic loss and environmental losses. Especially non-communicable diseases like diabetes, cancer, cardiovascular disease, chronic kidney disease, in the event of emergencies, this cohort of the community is amongst the most vulnerable in the population due to their ongoing requirements for consistently coordinated care, the care which is usually lifelong. And those affected by CKD especially are affected by unexpected disruptions, inability to access proper diagnostic services, treatment and care is greatly jeopardized. In a survey in 2021, it was shown that natural disasters affected almost 101.8 million people worldwide, accounted for over 10,000 deaths and more economic losses. These natural disasters can come in many forms like floods, earthquakes, tsunamis, volcanoes, or other unexpected events like war situations, famine, infectious disease outbreaks like the COVID-19 pandemic recently is a timely example for worldwide preparedness. And other events like unexpected road closures, power and internet outages, interruptions to war supplies, etc. And these unexpected events affect the most vulnerable group like old age, children, pregnant, or any death in the family and psychological demoralization. And preparing for the unexpected situations is of utmost importance in situations like this, in handling situations like this. In recent years, COVID-19 pandemic has provided a clear example of the challenges faced by the healthcare systems in providing essential health services to patients with non-communicable diseases, especially CKD population. The impact of COVID-19 on the health system has placed an added strain on this vulnerable population who had to deal with the risk of becoming infected while visiting the health facilities, or indeed the suspension or cancellation of non-COVID care due to healthcare capacity limits and lockdown policies. Health services have struggled to provide access to the ongoing incidence of new non-communicable diseases which needs diagnosis, management and care. So therefore, preparation for unexpected events is incredibly important for kidney patients. Coming to the disruptions to dialysis care in situations like this, they are particularly vulnerable group with respect to the disasters. Critical consequences of a lack of access coupled to an exponential increase in demand for dialysis as a result of trauma and injury from unexpected events can lead to critical failure of kidney services in affected area. The aftermath of all these disorders, with disruption of continuity of life, sustaining treatment for existing patients on dialysis, crush injuries, needing kidney replacement therapies, all these stressed the importance of preparing for the unexpected and supporting the vulnerable group. In India, the challenges due to COVID-19 pandemic were enormous, with 3 months of lockdown where no public or private transportation was available. Dialysis patients relied on the help of family and friends to travel for the treatment. Staff often lived in medical units to provide treatment. There was an overwhelming shortage of personal protective equipment as well. Recently, the beginning of the Russian and Ukrainian war, more than 800
I'm
medical
extremely
facilities.
sorry to disturb you, Dr. Sindhu. Are your
Ma'am?
slides not moving, or is it? I mean, are the slides moving? I cannot
No,
see
I'm
the.
not moving the slide, ma'am.
Okay,
I'm
right.
just
Sorry,
talking on
sorry
this.
to disturb. Right.
Okay.
Right.
More than 800 medical centers during the recent war have been damaged since the beginning of the war, many of which were dialysis centers. And coming to the disruptions to transplantation, transplant services are often suspended in terms of crisis, which leads to stress on healthcare system. Also, access to essential immunosuppressive medications for kidney transplant recipients is often disrupted in wake of a disaster, increasing the risk of rejection and allograft loss. So to tide over the crisis in some recent events like floods, where there was struggle for basic amenities, food, shelter, and clothing, and many of the hospitals being submerged in water with no electricity. Few hospitals somehow managed to run with some efficiency, ambulance running here and there and picking up the patients, flood relief team and boats to evacuate people from safe to unsafe to safe zones, and help to send dialysis patients, hospital staff, doctors to hospital. And doctors and staff overwork, they stay in the hospitals away from the family, and um, we somehow tided over the crisis successfully in floods and the COVID pandemic. But there is definitely an importance of making and optimizing the care and making a plan for the disaster response. It is clear that the transport issues were the most difficult to address. In such situations, home hemodialysis in some situations may be beneficial, but it is uncertain because of the power and water supply in some kind of disasters. And in some areas, all the acute automated peritoneal dialysis, because of the electric supply, they were converted to CAPD, continuous ambulatory peritoneal dialysis. And even in cases of some disasters, peritoneal dialysis offer an assuring response if the supplies are being given properly. COVID-19 positive patients were cohorted for treatment in individual units during the COVID-19 pandemic, and many health systems thoroughly evaluated the transplant recipients for the risk of infection and used telemedicine for post-transplantation follow-up. For the community as a whole, a comprehensive, adaptive framework with integrated kidney disease emergency response, that is public health emergency preparedness, PHEEP, may help reduce the difficulties experienced during disasters and aid in the capacity to recover services. So this is a resilience framework for public health emergency preparedness. Each spokes of the ethics and values wheel, that is the wheel in between, corresponds to an essential element of public health emergency preparedness. For example, in the planning process, comprehensive, adaptable, and dynamic planning process, engaging partners and other health professionals considering prevalent morbidities depending upon the hazard causing the emergency, and proper assessment of problems then that can rise. That is important. Coming to the collaborative networks like NGOs and incorporating them into the public health emergency preparedness, and educating them in the regarding the kidney disease. And coming to the risk analysis, it is key to making necessary adjustments through partnerships. Surveillance and monitoring promotes timely dissemination, updating information about persons who may have developed disabilities or morbidities such as AKI, and communicating adequately, vertically and horizontally with partners in health and non-health sectors, and passing key information to other professionals crucial to patient management. In addition to this, practice and experience include exercises, simulations, drills, or practice to build capacity for response and feedback. Workforce capacity is critical in such situations, and well-trained and knowledgeable staff should form the social infrastructure for the system. Staff need education and training in preparedness, including how to support direct patient need and preparedness. Governance and strong governance and leadership form the critical of all this preparedness. In the light of this, ISN RDRTF, that is Renal Disaster Relief Task Force. Over the last 20 years, the ISN Renal Disaster Relief Task Force has supported nephrologists and their patients in many countries, helping cope with and provide care in the aftermath of natural disasters. The task force works in close collaboration with this Doctors Without Boundaries when it comes to logistic supports during interventions and gathering volunteer nurses. Finally, the COVID-19 pandemic has aggravated an already insufficient global political health commitment on non-communicable diseases. Policymakers need to adapt integrated health strategies that prioritize prevention, early detection, and management of non-communicable diseases, including kidney disease. Healthcare services should provide equitable and proper access to care for chronic patients in times of emergency, and governments should include emergency preparedness plans in the management and detection of non-communicable diseases and favor the prevention of these conditions. And patients should plan for emergencies by preparing an emergency kit that include food, water, medical supplies, and medical records. Thank you.
Thank you, Dr.
Thank you. Yeah, Dr. Chakravarti, please go ahead.
Thank you, Dr. Sindhu. It's a very good talk, Dr. Sindhu. Just I want to share my own experience. This was way back in 2015 when Nellore actually were surrounded by floods, and I was working at KIMS Nellore that point of time, and all my dialysis patients actually they could not reach Nellore. And luckily we started that time, we didn't have this government dialysis unit during that time. So we started one satellite units in a place called Atmakur, which was 100 kilometers away from Nellore, where we actually diverted some of our patients to that unit. So what actually probably that is one of the things we have to link our satellite units as well. Sometimes when people cannot reach, we should be having that plan B where we can use the satellite units in emergency. Thank you.
Yeah, I mean, that was an excellent talk about the present year theme. What I want to echo is the same point Dr. Chakravarti has raised, because Andhra Pradesh being on the coastal area, it's more vulnerable to the natural disasters. With the cyclones that generally hit the border of Andhra, I think it's time that we learn from the Ukrainian crisis, which is a man-made disaster, as well as the natural disaster that has recently hit the Turkey and Syria, that we need to learn as to how we can gear up and what exactly should be the preparedness. We may not be the people who can give them the suggestions, but we are definitely the stakeholders of framing of the policies, since it's being vulnerable. And the way that the nephrology services are built up, especially in the southern part of the peninsula of India, starting from the hub and spoke centers or the isolated centers, I think we should gear up as to how we can face the disasters from the doctor and the medical personnel point of view, as well as from the patient perspective. Recently, we had floods and heavy rains which reached the Adilabad, Bhadrachalam, Kottagudem areas, which wherein the areas were completely inundated. But then, to our pleasant surprise, none of the patients had come in an emergency. None of the patients had missed their dialysis, and none of the patients complained of the transport challenges, or the medical personnel faced the transport challenge. That was because of the government, which not in this lines had thought about the spoke centers, but then to increase the reachability, accessibility, and equity and equality of the healthcare services, that patients could utilize, and not much distance needed to be traveled by them, that they could reach even in the time of calamities. So what I mean to say is, it is time. In fact, the theme that comes up every year is very pertinent. So it is, in fact, with the recent natural disaster, it's time that we learn from others' experiences and start looking at preventive steps, like the one which we had in the morning. There should be a cell, or there should be a committee, or there should be a forum, or there should be a team. Especially, we thought from Telangana forum perspective, but then you can think about from AP forum perspective, which can give certain suggestions as a forum, as a society, as an organization. You can give certain suggestions to the government with respect to the preparedness, especially when it is mostly catering to the vulnerable patients. As you all know, the CKD patients are vulnerable, dependent on the health centers for everything, starting from PD disposables to the PD bags, to the transplant drugs, to the HD services. Everything, they are dependent on the medical services. So if the medical services get interrupted, I am sure the morbidity is going to be high. So I think to overcome all these things, there should be framework of policies that needs to be laid down by the policymakers. I think, and the it's time that all of us, or probably at least some initiative, should be taken from the forum or the organization, the society, the WIN AP, or the AP State Forum can think about forming a small cell which also thinks about the framing certain guidelines regarding the disaster management. An excellent talk once again, Dr. Kirti. Thank you. Thank you so much. And thanks to WIN AP. Great going, great activities that have been enlightened and enlisted by Dr. Jiki. I think it's been a long haul for you that's going to come in the next few days. And congratulations and all the very best to the whole team.
Sorry to interrupt. Before you close, I just want to congratulate all of you, the women in nephrology. I should accept that women in nephrology are much stronger than men in nephrology. The way you people are doing, it's really good, and I appreciate it. Thank you.
Thank you, sir.
Yeah, it was an excellent presentation, Dr. Sindhu, a very precise one, and the management aspect suggested by Dr. Manjusha is well taken, and I think we will also in APSN will go ahead with the formation of a cell or a body which can coordinate the activities in times of emergency and of disasters. And I thank Dr. Chakravarti also. Men in nephrology is the body is very strong. That's why we have to
madam.
start
To
in
be
women
honest,
in
I'm
nephrology.
really impressed.
Anyway,
by
thank you so much for joining and
Thank you.
supporting us, Dr. Chakravarti.
Thank you, ma'am. Thank you, sir. It's a
And
pleasure.
Nehru
Thank you.
and others too.
Thank you, ma'am.
I thank the session chairs for lending their insights and experience on this critical topic. I'm pleased to announce that our next session will focus on the theme of International Women's Day, and we have the privilege to have as our session chairs Dr. B.S. Nehru, sir, Chief Nephrologist, Walter Kidney Center and Queen's NRI Hospital, Visakhapatnam, and Dr. Hitaishi Ma'am, Chief Nephrologist, Mansa Kidney Foundation, Tirupati. Over to the session chairs.
Hello, am I audible?
Yes, sir.
Yes, sir.
Yeah, good evening to everyone. Thank you for inviting me to be the chairperson for this Women in Nephrology session. And the theme of this year for the International Women's Day is embracing equity. This is a very good theme. First of all, women are fighting for equality with the men, And and the next one is women among themselves also should fight for equality. The races, the castes, the regions, everything is coming in the way of equality. So I feel the women should embrace equality in all respects and to fight with equality with the men also. Now I request Dr. Sirisha, uh, Associate Professor, to go ahead with her talk.
Thank you, sir. Am I audible?
Introduce the speaker.
Hello?
Yes, Sirisha, go ahead.
No, introduce the speaker, Hitashi.
I was not given details with me.
Yeah, okay.
Oh.
So Dr. Sirisha Gunam is Associate Professor from NRA Hospital.
NRA Medical College,
Good evening, everyone.
Chinakakani.
Okay, sir.
We both shared for the introduction, Dr. Hitesh and myself. So welcome, Dr. Sirisha. Go ahead with
Yes,
your
sir.
talk.
Yes, sir. Thank you. Good evening, respected seniors and all my colleagues. I'm Dr. Sirisha, working as Associate Professor in NRA Medical College, Chinakakani. Today, I would like to talk about and give a small presentation regarding International Women's Day theme, Embrace Equity. Embrace means to hold someone in one's arms as a sign of affection. This is the sign of this year's Women's Day theme.
1 second, Dr. Sirisha, I am not able to see you. Your video is
Sir?
not open. Your video is not open.
1 second.
She's screen share is going on.
Yeah, now I can see you. Yeah, screen share, you go ahead.
Yes, sir.
Yeah, please make it full
Yes, sir.
slide view.
So, International Women's Day, it is a global day done celebrating the social, economic, cultural, and political achievements of women. It was done annually on March 8th. It is one of the most important day. Significant activity is done worldwide as groups they come together to celebrate the women's achievements, educate and raise awareness for women's equality. They do rallies and they bring attention to issues such as violence and abuse against women, reproductive rights, and fundraising activities are done on this day for female focused charities also. Coming to the history, why it is celebrated on this day, it is the symbolic culmination of both the long public struggle for women's rights and more private struggle waged by every day by women that have made the celebration of this day possible. International Women's Day, it originated from labor movements in North America and Europe during early 20th century. On 8th March 1857, women working in clothing and textile factories in New York City, they are called as garment workers in the United States. They staged a protest against inhumane working conditions and low wages for the women. 2 years later, again in March, they formed their first labor union to protect themselves and
Sorry to
gain some
interrupt, Sirisha. Slides are not moving, Sirisha.
and gains. Now, ma'am.
Slides
No.
are not moving.
Ma'am, you do your one thing, ma'am. You unshare and reshare and select the screen, ma'am.
Okay.
Unshare it,
But
then reshare and select the screen instead of PPT.
I unshared it
Stop sharing
again.
and share again. Stop sharing first and then share again.
Yes. Now is it visible?
Yeah. Keep it in slide mode.
Not slideshow, Sirisha.
Not full view. So full screen view.
Yes, ma'am. Is it visible now?
Ma'am, I will request instead of PPT, while you click on share screen, instead of PowerPoint presentation, there is an option of select screen. You select that, ma'am.
Entire screen view.
Yes, ma'am. Yes.
Okay. Is it visible now?
Yes, yes.
Yes, ma'am. Now we can.
Okay. So, so on 25th March 1911, a triangle fire accident took place in New York City, in which many workers were trapped in a 10-story building in the fire accident. Over 140 workers, mostly Italian and Jewish immigrant girls, they lost their lives due to trapped in the story building. So on this day, International Ladies Garment Workers Union, they led many protests against this tragedy which occurred due to lack of safety measures, and they called for a silent funeral march which brought about together 1 lakh people. This incident, it had got significant impact on the labor legislation about the horrible working conditions leading to this disaster. First, initially International Women's Day, it has no date. Americans, they used to celebrate on last Sunday in the February. Then German delegates, they proposed a special Women's Day to be organized annually. It was marked on March 19, 1911 in Germany, Austria, Denmark, and some other European countries initially. Across Europe, women demanded the right to vote and protested against this employment sex determination. First International Women's Day was held on March 8, 1914 for the first time in Germany. On this date was chosen because many reforms occurred. The most important one is the right to vote was given to the women. On this day, it got associated with far left movements and governments until its adoption by the global feminist movement in late 1960. It was considered and a holiday was proposed on that day. Coming to this year's theme, aim of this International Women's Day 2023 theme is Embrace Equity. It is to get the world talking about why equal opportunities are not enough, because people start from different places. So true inclusion and belonging require equitable action. Equity means they want to create an inclusive world by challenging gender stereotypes, to call out discrimination and drawing attention to bias and seek out inclusion. So this is the difference between equality and equity. In this equality, for a group of persons, resources, same resources are given. Here, one lady is handicapped, one is child, but all these persons are given same resources. Whereas in equity, each person's circumstances are understood and the resources are allocated according to that to reach an equal outcome. This is another figure showing the difference between equality versus equity. In equity, the resources are given according to the requirement to reach an equal outcome. So that is the difference between equality and equity. Equality means each individual or group of given people are given the same resources or opportunities. Whereas in equity, it recognizes that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. So it is not giving everyone exact the same thing. So equity can be defined as giving everyone what they need to become successful. When we embrace equity, we embrace diversity and we embrace inclusion, and we embrace equity to forge harmony and unity to help drive success for all. So equality is the goal and equity is the means to get there. Through the process of equity, we can reach equality for all. Coming to our nephrology practice also, there are studies showing sex and gender differences in chronic kidney diseases and access to care around the globe. These studies, they have shown CKD is more prevalent among women, but the prevalence of end-stage renal failure and especially receipt of renal replacement therapy is higher in men. These differences may be due to the physiological and structural risk factors that independently impact the disease risk. But there are social and gender related inequities are also seen across the globe. Women, they particularly, they live in poverty and they have less education and are dependent on others for the healthcare decision making. So this culture and geography impact on kidney care when in places where resources are limited, such as sub-Saharan Africa, Mexico, they have illustrated in these areas. And in this study, gender inequality in kidney transplantation rates were also seen. According to the data from the Canadian Organ Replacement Register, men experienced 20% greater kidney transplantation rates relative to the women, and the 5 years probability of getting a transplant was 47% for women, whereas it's 39% for 47% for men and 39% for women. This difference we also observe in our day-to-day practice also. So I would like to conclude this International Women's Day, Embrace Equity. It's not just something we say or something we write about. It's something we need to think, value, and embrace. Thank you.
Thank you, Dr. Sirisha, for the good discussion. So while we are celebrating WINS India's achievements, let us also strive for equal opportunities for our women patients with kidney diseases when they are receiving renal replacement therapy or kidney transplants, all that. So let us work up and give a world free of discrimination, be it gender-wise, racial-wise, or socio-economic status-wise for our next generation. Thank you. Thank you very much.
Excellent talk, Dr. Sindhu. You have brought out new points, and it's an eye-opener for all the people. Thank you very much.
Dr. Sindhu, that was a very good talk to ensure that equity is available to all the women over the world. Congratulations, Sindhu. I'm
Sirisha.
sorry, not Sindhu.
Thank you.
Thank you, ma'am, for the thought-provoking message on an equitable future for women. I express my sincere gratitude to the chairpersons for the valuable contribution to the session. Our next session will focus on kidney diseases in the post-COVID era. I am honored to introduce our esteemed session chair, Dr. Venugopal sir, Head Department of Nephrology, Care Hospital, Visakhapatnam. Over to you, sir.
Shisha ma'am, stop sharing your screen. Shisha ma'am, you have to stop sharing your screen, ma'am. Thank you.
Venu sir, please introduce Dr. Shiva Parvati sir. Venu sir, are you there?
I don't think he is there.
Is the other chairperson available?
Uttara madam is also not available, madam. Jikki
Can you
madam.
give a call to Venu and Uttara to join?
I have called madam. Venu sir said I will join. And he is in travel like that.
Bhargav or Siddharth, look into that they join soon.
Taiwan, you can put some other people as chairpersons. No worries. Please go ahead.
Okay. Jikki madam, will you chair the session, ma'am?
I don't mind, but they are on the way to enter into the sessions, no?
Just
It will not be
focus
correct.
We'll wait.
Just
We'll
allow
wait.
at least 2 minutes for them to join.
Okay.
If they say they are unable to join, then I would come into the picture.
Okay. Okay.
Good evening.
Venu has come. Good evening, Dr. Venu.
He is still not there, ma'am. He's not at there.
Good evening. Am I audible?
Yeah. Dr.
Yes, sir.
Venu.
Yes, sir.
Good evening, everyone. Thanks for the organizers for giving me this opportunity to chair this session post-COVID renal illness. We went through a lot of hardships during the COVID times. We all know that. Initially, it was thought that COVID has got no direct relation with kidney diseases, but later on it was found that there are a lot of kidney diseases and kidney problems that may arise out of COVID. So many papers have been published regarding this, ranging from the effect on podocytes, the effect on endothelial cells, the effect on epithelial cells, and producing a wide variety of nephrotic illness, renal failures, interstitial diseases, and whatnot, and including renal ischemias. So I'm very sure that Dr. Shiva Parvati from Tirupati will enlighten us on this topic, and let us listen to Dr. Shiva Parvati.
Thank you, sir. At the outset, I would like to thank WIN AP organization for giving me this opportunity to speak on this great occasion, World Kidney Day, as well as the Women's Day, International Women's Day. So I would like to share my screen. So can you see my slides? Can all of you see my slides?
Yes.
Yeah, thank you. So myself, Dr. Shiva Parvati, I am working as consultant nephrologist at Amara Hospital, Tirupati. So when Saivani madam asked to discuss on some topic of my choice, I specifically selected this topic because during the COVID, our hospital has been one of the major receiving of all these cases. So we had pretty good number of COVID cases and renal involvement. Actually, I went through a lot of AKI cases during the COVID period, but because we have a good recovery outcomes in our hospital, a lot of people started coming even for the post-COVID care for different departments, and that's how we had experience of this post-COVID renal diseases. And throughout my talk, I just tried to tell you whatever I have seen, and I request all the seniors to throw your light as and when it is required. So this is what has happened from the COVID. So we all have shifted from examining the patients to online consultations, going to school to online schools, from work from home. So these things we have already seen, and we have a good amount of experience with it. Now in 2023, so what we thought is we all have reached a new normal. But is it really normal? That we have to discuss, and at that part I'm going to discuss now. So the outline of my discussion is to be, I'll go through 4-5 case scenarios. That is AK and CKD in post-COVID, dialysis patients in post-COVID. And specifically, I'm going to talk few minutes on the organ crosstalk with emphasis on lung, kidney, and gut. And management of these patients with renal disease, how is it different from pre-COVID? And take-home message. So this is a case one. Here is a 74-year-old male patient who is a diabetic, hypertensive, and he is also a patient of COPD who got COVID in August 2022. He also had a history of CAD with PT. So he has all the comorbidities. He presented to us with complaints of shortness of breath and decreased urine output in November 2022. So at the same time, he had decreased urine output with accelerated hypertension and acute pulmonary edema, for which we have to do 3 sessions of hemodialysis, after which he's admitting creatinine was 3.9 and he has stabilized at 2.1. He was maintained like CKD patient without any dialysis requirement. But this patient had come to us with recurrent admissions for breathlessness in the last 3 months. The diagnosis for every admission was pneumonia with fluid overload. In January and February last month also, we have Admitted the patient. We treated him with diuretics. He responds. I see the patient as well as the pulmonologist sees the patient. He gives some nebulizations and he completely recovers. That even he goes home. What is more concerning is his attendant comes to me and he tells me he has been a COPD patient on follow-up with a pulmonologist elsewhere, but he has not been admitted like this, he told. So we thought we have advised for pneumococcal vaccination. Yes, he has done it. Because of recurrent admissions with pulmonary edema, I asked him to go for renal angiogram to rule out the renal artery stenosis, but they have explained the risk because he's already a CKD patient, the risk of exacerbation of the renal dysfunction, for which they were not willing. But the utmost that I can do with this patient is only Doppler. It is not suggestive of any renal artery stenosis. Right now, I have this patient, every time he gets admitted, his HRCT shows bilateral pleural effusions and ground glass opacities. So this is a particular patient who is a post-COVID with all the comorbidities, continues to present to us with symptoms of fluid overload and a CKD status, which is a mild increase or decrease after treatment. So the summary of first clinical scenario is a CKD patient with recurrent fluid overload and a compromised pulmonary function, which we are going to discuss later. So this is a case 2. He is a 37-year-old male patient who presented to cardiologist with complaints of shortness of breath of 1 week duration, but he has no comorbidities. He had a COVID in 2021 February. He received steroids. But now for his breathlessness, the cardiologist has done the echocardiogram and it is shown dilated cardiomyopathy with ejection fraction of 32%. He was referred to nephrologist for proteinuria evaluation because he had a significant proteinuria of 4 grams per day. But clinically, he has no edema, no hypertension, normal albumin levels, normal complements. But however, he has hyperlipidemia. He was right, currently admitted for stabilization of CHF in our hospital. So what could be the etiology? I told the patient that your evaluation of proteinuria would be done after stabilization of the heart failure, probably based on the clinical findings, significant proteinuria, normal albumin levels. I thought of a secondary FSGS, probably secondary to obesity, secondary to steroids, and heart failure. So the summary of case 2 is a glomerular diseases post-COVID. What are the risk factors? Evaluation and management with history of background immunosuppression and immunomodulation. That we have seen lot of publications that COVID can cause hematuria, COVID can cause proteinuria. But COVID patient received steroids or received remdesivir, not in my case. So if they are coming after certain period of time with proteinuria, what are our differential diagnoses and how are we going to manage these patients? This is case 3. She's a female 28-year-old farmer, completely healthy before presentation to the hospital, but she had an episode of 30 loose stools associated vomitings. So she was brought here with acute kidney injury. So in the emergency department, we have treated her with IV fluids, but she developed severe shortness of breath and 2D echo showed severe PAH with distended IVC. Hence, we have done one session of HD and fluid was restricted. So what we usually do in emergency department, if the patient is not showing any signs of fluid overload, we try to hydrate her and see for recovery of renal function. But this patient developed immediate fluid overload. So we did not give much fluid, so restricted the fluid. She required hemodialysis for a week period. She has recovered from AKI, but at the time of discharge, she had a persistent PAH on follow-up now with cardiologist. PAH workup was completely negative, like when they're done in retrospect, except for history of COVID, which is requiring treatment with admission and some injections because they're farmers. We don't have the reports whether they have taken steroids or remdesivir and all, but she has a significant COVID infection. So this is a case that is fluid management in patients with AKI, difficulties faced due to the PAH and compromised lung function. So we are all going to see this type of patients now. And this is case 4. That is a 32-year-old male who had come with complaints of chest pain at 3 a.m. Investigated, he had an ACS, anterior wall MI, CAG was done, it should have occluded L6. And he was planned for PTCA, but after the PTCA, his RFT was deranged and he has maximum serum creat was 2.1. We have managed him somehow with discharge creatinine was 1.8. Follow-up at 3 months and 6 months, his creat was 1.4. Though it was 1.4, he was in stage 2 CKD. If we ask in retrospective, he says that he had a COVID because he's 32-year-old male. Now, of course, now we are getting a lot of MIs in a younger age group. Of course, we don't know the reasons. COVID could be one reason. So he had a COVID 6 months ago, self-treated at home, but there's no history of any major immunosuppressive usage. So this we know a lot of things are happening around the communities in everywhere. Healthy people who are physically active, they're having a lot of MIs. We don't know. See, not that these patients suffer COVID. We may not have history of COVID, because sometimes patient may have a self-limited illness. But to have a self-limited illness, our immunity must have been so strong. So what are the immunomodulations that have happened in these patients also, we don't know. And some patients who have taken treatment, the side effects of the immunosuppressive drugs also we don't know. But we are seeing a cohort of people whose immune modulation have led to some end organ damage, which is associated with kidney disease. So to summarize of this case 4, now as a nephrologist, we are going to see an increase in the burden of cardiorenal syndromes, and to say indirectly an increased prevalence of chronic kidney disease, because most of them we don't calculate the GFRs. Means of course nephrologists do it, but the physicians or the cardiologists, they look at the creat. It may be 1.2, 1.3, 1.4, but if we calculate the GFR, definitely they would be in stage 2, stage 3 CKD, where a lot of things can be done, but these people are missed. So this is a case 5, who is a 76-year-old male. He's already on end-stage renal disease, CAPD, but continues to suffer from breathlessness despite adjusting to PD prescription. So we have changed him to hemodialysis, but still he requires oxygen support during the hemodialysis because of hypoxemia. And every time we get a chest X-ray and pulmonologist opinion, he says the pleural effusions are significant. And so he does a pleural fluid tap. Of course, we have ruled out the pleuroperitoneal fistulas in these patients. The COVID associated comorbidities could be CAD and PTCL. And he also says that every time he has a running nose, he says, I have a flu-like symptoms and persistent cough. He had a past history of COVID requiring hospitalization and NAV also, because an elderly male patient, which is approximately 6 months ago. So to end this synopsis of case 5, persistent and hypoxemia and cough in patients who are on HD and PD despite aggressive and adequate fluid removal. So I just mentioned 4 or 5 cases to have a examples of what I see regularly. So would like to start our discussion, say that some of the transitions or transformations are very obvious, as you can see in the top picture, but some are really not. See, if you see, this is a normal lung, this is the smoker's lung, and this is the COVID lung. Okay, so these transformations, unless you suspect, unless you order some investigation to document this, we are not going to see this transformation. That means every patient who comes with AKI or every patient who comes with CKD is not normal. Means his lungs have been undergone a transformation phase through the COVID. So from the last 2 to 3 years, see, you may get a mild COVID or you may get a severe COVID. Definitely your immune system has worked something, and it has affected lungs, heart, and other organs. So when you have this new presentation of kidney involvement, we need to check the background status, keeping in mind that we are living in a post-COVID era. So this is a slide which is released from the CDC, and they say that approximately 1 in 5 adults aged 18 plus have a health condition that might be related to their previous COVID-19 illness. Could be neurological, kidney failure, musculoskeletal, cardiovascular, respiratory conditions, blood clots, and other vascular issues. So we need to keep in mind that probably this could be related to COVID. What if it could be due to COVID? Could we do something now? Yes, sometimes we can do some of the approaches that I would be going to discuss in the next slides. So this is an example that Hiroshima, Nagasaki, the acute effects were gone, but what we have seen, entire world has seen 5 to 6 years after the bombings, the incidence of leukemia increased noticeably among the survivors. And after about a decade, survivors began to suffer from thyroid, breast, lung, and other cancers at higher rates than normal. So this is a experiment. I mean, this is the experience that we have from the past natural disasters. So we are going to have such experience, or all of us have to be vigilant in the coming next 5 to 6 years. What would be the after effects of this COVID infection? So with this background, I would like now I would like to discuss argon crosstalk. Though argon crosstalk had been extensively studied and extensively published in patients with acute kidney injury, now we have to correlate this to our current scenarios. So as we all know that the symptoms of kidney failure, like uremic toxin accumulation, metabolic acidosis, electrolyte imbalances, fluid overload. They are all known conditions. Of course, we know the mortality, but something beyond this, there are other factors which could not explain the mortality in AKI patients at all. What are these other factors? Are the other organ injuries. So if you see that uremic toxins, hemodynamics, fluid hemostasis, inflammation, hormone, nerve reflex, and metabolites, they all lead to involvement of the lung, heart, liver, gut, and brain. Especially the prostacyclin PGI2, which is secreted from the alveolar vascular endothelial cells in the lung, they would regulate the renal blood flow and glomerular filtration. And what is said is during this COVID, the endothelial cells have been completely damaged, and the release of prostacyclins could be reduced even in post-COVID states also, because that heals by fibrosis. And as we all have seen that in the management of COVID patients also, we have measured serum IL-6 levels and we have given IL-6 antagonists also. It is considered to be more critical mediator of the kidney-lung crosstalk, and IL-6 deficiency was protective against AKI. So what I would suggest is, if you feel like something, how to understand whether this patient is going to get renal involvement out of my viral pneumonia or out of my bacterial pneumonia. So use of IL-6 could be of use, because now IL-6 is no more considered to be a research molecule. Help to the COVID conditions, we have all assessed IL-6 levels, and we have all used IL-6 levels to take our clinical decision makings on use of like hemodialysis, plasmapheresis, CRRT, as well as a tocilizumab. And similarly, pulmonary edema after AKI is not only associated with fluid overload, because this I see daily. The legs are completely dry. If you see the patient, the legs are completely dry, but the lungs are full with crabs. I really fail to understand and explain what type of syndrome is this. Then this is what it is said that the reduced pulmonary fluid clearance also is very, very important. It is because of the downregulation of the sodium potassium ATPase present in the pulmonary epithelium and the ENaC channels, which is present in the pulmonary epithelium by IL-6 levels. So the patient may be dry, but because of elevated IL-6 levels, he may be decreased pulmonary fluid capacity. More often in our ICUs, in intensivist, he feels like, please do dialysis. This patient is going in severe congestion. I say that where is the evidence for fluid overload in this particular patient? They say lung crabs are there, but legs and other, everything is dry. So can we remove this fluid by hemodialysis, or we have other modalities? So these are the important decision makings based on this pathological information. There are certain novel biomarkers that they have been studied, like mitochondrial damage associated molecular patterns and alpha klotho, though these are not really available for us to do, but a lot of research can be done, because every year apart from the social and epidemiological things that we progress in kidney health, this helps us to serve better to our patients. So this I have the systemic inflammatory response syndrome that we have seen in all our patients. Even now we see a lot of the patients who come with sepsis mods to us in a late stage, treated with some antibiotic in the peripheries, and they come to us in refractory shock on 1 or 2 inotropes, and we try to manage the associated AKI. And as a nephrologist, we become the team leader, because we don't know, because they don't interfere with the dynamics like dialysis, they don't interfere with the drug dosages. So ultimately, the treating decision of the case comes to us only. So whether to give vasopressors or what type of dialysis should we do? Should we do hemophil? Should we do CRRT? So having an understanding of the entire internal milieu is very, very important to manage these patients. And they have seen that meta-analysis, the most common abnormality in a post-COVID patients in the lung are decreased diffusion capacity. That's why I told in my case 5, even in hemodialysis patients or PD patients, a lot of these hemodialysis patients, they're even subjected to angio, thinking that these patients must be having some coronary disease, because they're continuously breathless despite the fluid removal. They have seen that the post-COVID lungs are continuously hypoxemic because the diffusion capacities are low. And that is why we need to give some amount of oxygen to culminate the other reactions that happen out of hypoxemia. Okay, so that this explains the requirement of NIVs in patients with severe sepsis and MOTS also. And nowadays we are seeing increased dependency. So one day you give ventilatory support, the patient comes out. But if you miss that one day of giving that ventilatory support, he continues to sink in and ultimately dies of severe sepsis and also. This trickling point, initially we used to wait for 3 to 4 days, give antibiotics, see the response. Now the lung involvement in AKIs are coming very closer. Means it is not giving us much time. We cannot give 6 hours fluid. We give 12 hours fluid, see the response. No, we are not having that amount of time because the patient is a compromised patient. The lung is a compromised lung. The vascular endothelium is a compromised endothelium. You may be a severe COVID patient or a mild COVID patient. That lot of research has to be done in all these things. And what is leading to this is difficulty to give fluid challenge in this field. I see that I cannot completely rely on give fluids for the entire night. Just inform me in the morning whether output is there or no. Every hour I have to call you. If you are giving 200 ml fluid in a trauma patient also, I am very cautious because in trauma patient we suspect rhabdomyolysis and we can give up to 300 ml per hour. But with this background of this pandemic, are we justified in giving liberal fluids comes to a question, and liberal fluids are no more taken in this present situation. And so this is about the lung and the kidney in the present situation. Coming to the cardiac involvement, cardiac failure was found in 60% of the patients with AKI in the intensive care unit, and it increases the risk of subsequent heart failure by 58%, MI by 40%, and stroke by 15%. And in my hospital, they say that if the patient gets admitted under me once, next time he's going to get admitted under a cardiologist. If he is admitted under cardiologist, next time he's going to come for follow-up under nephrologist. Such close are the associations between the kidney and the heart we are seeing nowadays, because a lot of patients were doing angiograms, PTCAs, and they are culminating in CKDs. And a lot of CKD patients, they are having associated increased atherosclerosis because of the increased usage of steroids and the other immunosuppressive agents, and they are landing up in acute MIs and AF. Atrial fibrillation. Every admitted patient, every other patient we used to see AF. Actually, we thought of doing some study also because we don't know. The conducting system of the heart has been affected so much, whether due to this direct invasion of the virus or because of the immunomodulated drugs that we have used, of course, is uncertain. And particularly, there is more incidence of right ventricular dysfunction, which is identified in post-COVID patients. And we have come up with a novel markers like, see, in right heart failure, you cannot completely rely on IVC diameter because it is already dilated. So what are the other things like that is called as TAP-SC, that is tricuspid annular percussions during the systole. We see that. So that usually it is used in a pulmonary embolectomy patients, whether to see that right ventricle is functioning or not. So before, in a compromised patient, in a patient with a limited in a patient who is already having some background history of cardiac dysfunction, it is better to assess, just don't look at the EF, ejection fraction, and try to give more fluids, because ejection fraction is going to tell you about the left ventricular. Also look at the right ventricular function, and if the right ventricle is compromised, you be cautious with your fluid. Then you can have a little better outcome, so that we will not overload the patient. And it is seen that a lot of times, if the ICU are not monitored by the nephrologist, they end up in fluid overload. And the most common indication for doing dialysis is a pulmonary edema. And the last one is a gut and kidney crosstalk. As this slide shows, in the uremic milieu, a lot of bacteria can translocate, and a lot of mediators, inflammatory mediators also translocate. So what happens in these post-COVID patients, because of the steroids, their gut are already leaky, they're already erosive. And in the last 6 months, a lot of patients with AK has acute G, and acute G is also so typical. They have 30 to 40 loose stools, or 20 to 30 loose stools, especially in this part where I practice. They present with some around 3.5, 3.9 to 5 creatinine. Just do 1 or 2 dialysis. That's all. They'll be very good. They'll be very happy. They come out and they're discharged with normal serum creatinine levels, and blood urea levels out of proportion to serum creatinine. Creatinine is just 2 only, but urea levels are around 120, 130, 140. So this type of clinical scenarios we are seeing off late. So the reasons could be the already damaged mucosal membrane secondary to the COVID, as well as the immunosuppressants that we have used. The steroid-induced gastritis, ulcers, gastropathy makes them vulnerable to repeated GE episodes, and they're more prone to AKI and complications. So management and outcomes, I try to represent the present patient that I'm seeing. So I just try to do this line diagram. So these psychological issues, everybody has a psychological issue because every family has lost someone or the other due to COVID. On the top of this, dilated RVs, compressed lungs, erosive ulcers, and to mediate all this, the hardworking kidneys. So this sort of patients we are dealing. So it may be a simple AKI, but the AKI that we are seeing 4 years before and 4 years after are entirely different because the AKI happening in an internal milieu itself has been changed. And my experience at this hospital, the total number of AKIs in the last 1 year are 56 cases, that is 24% of the nephrology admissions, and of them requiring dialysis are 25%. If you see the indication for HD, 75% it is fluid overload and 35% it is azotemia, and the mortality is around 14%. Usually the mortality is around 8 to 9%, but we have most of the times they come on triple inotropes, dual inotropes, already tried 3-4 antibiotics elsewhere, and they come to us as a tertiary referral hospital, and we take all sorts of patients. We try to do everything, but still our mortality is 14%, and the number of CKD patients are 160 to 70% of our admissions are CKD, and surprisingly 58% are due to fluid overload. 40% are due to respiratory failure and 2% are due to CVS. So when I worked in NIMS, I have done a study in ICU admissions in acute renal care unit. At that time also CKD was there. In the admissions for CKD, accelerated hypertension, catheter-related bloodstream infections, they are all more common. Urinary tract infections are more common. Nowadays, apart from urinary tract infections are coming less actually, but these fluid overload, pneumonias, recurrent pneumonias, of late I'm seeing more. So I thought I would discuss these things with a fellow nephrologist and would like to know their experience and outcomes. So with this, the theme for this year is preparing for the unexpected and supporting the vulnerable. Actually, if you see the patient as a nephrologist, we are seeing only this much. But in the community, we have a more number of people who are more prone to develop AKI, CKDs. They're all vulnerable people, the high risk people, diabetes, hypertension, post-COVID. This big chunk is a post-COVID now. So we are going to see these people in the future coming up with small components of kidney-related health issues. And I think we're all geared up to see this. And I request all the seniors to share your experiences and what are all the research things that we can do in this patient so that to form a guided protocols to deal with these patients. Thank you very much. So how to avoid all this? I thought I will tell you in the last one. So trying to live in harmony with the nature, that is the most important thing. So disharmony impels us as well as the fellow creatures. So de-stress yourself, practice some yoga, try to be in harmony with the nature so that we can avoid all these pandemics and live a happy life. Thank you so much again for giving me this opportunity and patience hearing.
Thank you, Dr. Shiva Parvati. I can't agree more that this is a wonderful presentation. I guess all the audiences have a wonderful last 20 minutes. Before opening the discussion to the forum, I have one query to Dr. Shiva Parvati. What is your experience of renal lesions post-vaccination against COVID?
Yes, sir. Actually, I have seen only one patient, sir. She presented with, she's a young lady, 16-year female. She presented to us with HUS, and we have done the biopsy. She had developed a TMA, sir. And after that, I have gone through the literature, and they have published a lot of reports on instance of TMA post-vaccination. There are also reports of TMA during the COVID illness also. But vaccination, I have seen one patient with TMA. Other patients are extremely, I didn't have an experience to see other lesions, sir.
Okay. If I'm not wrong, there was a discussion in our AP Nephrology Forum quite some time ago, and Dr. Chakravarti initiated this discussion long ago, if I'm not wrong, on COVID vaccination and renal illness. Am I right, sir? If you are there in the audience?
Yeah, correct, Rani. Yeah,
sir.
we did actually see, unfortunately, there was a lot of the CKD, stable CKD patients. And in fact, I had 4 of my transplant patients also who are completely normal graft function for 2 to 3 years. Post-vaccination, their creatinine went up within a time of 2 to 3 weeks. I can't explain any other reason. So these are the observations which we did.
Could you do biopsy, sir,
Actually,
on these patients? And
Yeah, these patients, like they had a mild increase in creatinine, and it was sort of stabilized from maintaining from 1.2, it went up to 1.3, 1.4, and sort of stabilized again around 1.3, 1.4. These patients, only one patient we did a biopsy because it went up quite significantly. She had a rejection actually. She had a acute cell-mediated rejection which was there. But beyond that, we didn't biopsy the other people. In fact, one of those patients actually succumbed because she had that same time her creatinine went up, and within 2 months, she actually succumbed to the illness. She had another second episode of COVID during the same this thing, and she succumbed to the illness.
Actually, what happened, sir, in our hospital, one patient, he was on stable CKD, but he developed failure after he reached CHF, and we have to initiate dialysis after COVID vaccination. But during the COVID illness, I used to tell the patients, don't deny vaccination. Because every person used to tell, I had a vaccine, that is why I got this complication. Whatever the complication, they come to hospital, they tell this. So at that time, used to promote more vaccination, but later on, once the research and articles have come down, we are cautious on giving vaccine, especially to the pregnant ladies or reproductive age group females. I think the things that I've seen are more common in females, sir, actually. If I don't know, Chakravarti sir, patients are males or females, but whoever has got these things are especially reproductive age group females, sir.
Yeah, this transplant patient who succumbed, she was a female actually.
Yeah,
But
yeah,
we have
yeah.
seen,
So,
but we have seen across actually. In fact, even the stable CKD patients also post-vaccination. But it's not very common. I won't say it's very common, but definitely these are people who had very stable kidney function for a long period. Except
yes,
for this particular episode of vaccination, there was nothing else to explain.
yes, sir. Even the published reports state that women are more prone, as Dr. Shiva Parvati was telling. Yeah. Any other experience from other audiences in the state, across the state?
Sir, I want to convey my experience, sir.
Yeah, please.
In post-COVID era, I am seeing more of pulmonary arterial hypertension in our maintenance hemodialysis patient. They are presenting with nephrogenic ascites like thing, and with simple sildenafil, they are becoming normal, sir. And in patients presenting with nephrotic syndrome, membranous nephropathy is the common etiology, sir. And after biopsy, I am getting membranous nephropathy, and I am not finding any reason for the membranous secondary causes and all. And some of them are remitting spontaneously also, sir, and are having mild to moderate proteinuria, sir. And during COVID era, when patients were having AKI, the mortality was quite high, sir, and majority of them who were dialyzed, 80% were succumbed, sir. Only 20% were alive, even after this hemophil and all also, sir. But maintenance hemodialysis patients, they were strong. But AKI, after COVID, if the patients were having AKI, they were succumbed, sir. And biopsies, majority are this membranous nephropathy. And now I am seeing, like Shiva Parvati is telling, this fluid overload is very, so most commonly our critical care people are giving more fluids, and they are going to ventilators, and in the ventilators they are getting VAP, and mortality is high. And now fluid restriction protocols are to be followed after initial giving fluid bolus, and after that assessment, fluid restriction is better in present scenario in all AKI patients.
Thank you very much.
That was an excellent presentation and exhaustive presentation by Shiva Parvati of her experiences which she has shared with us. And that was very excellent. In our experience, I have not seen any post-COVID vaccination problem. But COVID-related kidney problems, we have sent for publication, which will be done soon, which probably you will have an access soon. And about the post-COVID vaccination-related problem, this is probably a very small number compared to the huge number of people who benefited out of vaccination.
Yeah, I agree.
Of course, it only goes on record to say that COVID vaccination also has produced some problems.
Yes.
Yeah.
And any other experience all the other members can share?
Yeah, I would like to just step in because ours was the nodal center for the COVID and we had enormous number of COVID patients. But what I would like to differ is, I mean, not that, I mean, we are finding pulmonary arterial hypertension, all these things, but our experience in the post-COVID scenario is little young hypertensives with CKD are being admitted quite in good numbers. The other recent thing that we have noticed is there's a surge, an absolute surge, because we treat the retroviral patients with CKD as well. There's an absolute surge of retroviral patients with CKD getting admitted. I'm really not sure whether there's any link because COVID apparently is not happening now. Coming to the COVID experience that we had enormous numbers. We had publications, a few are yet to come. We had maintenance dialysis patients who got admitted, the maximum mortality in them. The COVID AKI patients in 1 and 2 waves, we had about, I think, 190 patients. That's also going for publication. But a little increase in mortality is observed in the wave 2 compared to wave 1. And we had also transplant patients, though not many, about, I think, 20 in number. The mortality was very high in the transplant scenario. Apart from this, the COVID vaccine, we have a case series of about, I think, 8 to 10 in numbers, wherein again, the glomerulopathies were common compared to the proliferative glomerulonephritis. I think proliferative, we just had one, the rest are all non-proliferative. So that's as far as the COVID vaccine. The other thing that had come up in publication for us in 2020 was pregnancy, COVID, and AKI. We did manage tracheies in the COVID scenario as well, where the patients were having multi-organ failure. Of course, we were fortunate enough to salvage all the mothers. That was very less in number, 6 in number. That is already published in SJKT. The other thing that we had, because ours was nodal center, was mucormycosis. So we had about 22 patients of COVID-related mucormycosis of various kidney disease profiles, starting from CKD to AKI to transplants. The transplants succumbed. The dialysis could do relatively better. The AKI, I think they just lost the follow-up. The other entity that we tried to look into was the follow-up of the AKI patients going into CKD after the COVID AKI. Though the loss of follow-up was significant, what we could notice is that I think more than half, nearing to 3/4 of the people whom we could follow up had developed CKD. That was relatively high numbers. Maybe we were biased or skewed because of the less numbers of follow-up. Numbers of follow-up compared to 190 population of AKI, we had about only 50 plus population of the follow-up at the end of 1 or 2 years. So this is a brief experience that our center has as far as the COVID is concerned. The other thing is a COVID in children. Yes, we had a not a neonate, whatever it is, 3-month baby. I think that is infant. So that was the youngest age that we had. Pre-renal it was. And then the highest age was about 11 years, RPRFs. Of course, they went LAMA. We did dialysis for those patients as well. So this is a diverse experience that our center had as far as the COVID is concerned. But post-COVID, I mean, we are seeing a little hike in young CKDs, young hypertensive CKDs. I'm not sure whether we can call them as CKDU, because by the time they present to us, the pressures are a little on the higher side. So that is a group which we are seeing. And off late, over the last 10-15 days, we are seeing a true surge in retroviral CKD patients. Absolutely not sure whether there is any COVID relevance or not. So this is our experience in brief. Thank you. Thank you for the opportunity.
Thank you, Manjusha, for sharing your experience. You have been modest in telling that it is brief. It is a vast experience, I guess. And there are no other questions and comments. I thank once again for the opportunity given to me by the organizers.
One question in the chat box, sir, by Swarnalata madam.
Yeah, please read it out.
We saw variety of kidney diseases like FSGS, TME, anti-GBM, PIGN, and membranous nephropathy in post-COVID.
Actually, we also have seen a lot of patients of membranous, ma'am. Actually, as you said, if in the last 1 year, 80% of my biopsy reports are membranous nephropathy. Only the rest are FSGS actually, and only one we had MCD because we didn't get any EM. We don't know whether it is also MCD or FSGS. As I said, most of them could be immunomodulator, as we thought a lot of antibodies are involved in membranous nephropathy. We did PLA2R in all of them, and we could not get any of them. 2 patients were PLA2R positive, the others are negative. So that is my experience with glomerular diseases in the post-COVID era. But what I see is in this, most of them are at least 8 to 10 grams proteinuria, ma'am. As contrast to Saivani, madam, these patients, and I have given rituximab to them also, but the response to rituximab is also very less. I used to call Swarnalata and ask mother, how much time should I wait? Because it's already 3 to 6 months, but still they are not responding. The response to immunosuppression also has come down, maybe in a cohort of patients that I have seen, to rituximab at least.
Yeah. Thank you. Dr. Saivani, are there any other questions in the chat box?
No, sir. No.
Shall we conclude the session?
Once again, I thank the WIN AP chapter for giving me this opportunity, and all the seniors for giving your insights. Thank you very much.
Thank you. Thank you so much.
I express my sincere thanks to our session chair. This was a very informative and interactive session. Let's open the floor for group discussion.
Jikki
I
madam.
request Dr. Hitashi to give her comments. Dr. Hitashi, are you there?
Oh, yes, ma'am.
Sorry that I had taken up your responsibility. I mean,
No,
the,
it's
the
yours
request
only.
responsibility. And thank you for that, for accepting. Okay. In case I don't join, you would be able to take over.
Okay.
Okay.
Actually, I
give your
appreciate and
comments on
congratulate.
this.
Yeah, I appreciate and congratulate in India for achieving so much, and then in a short time. Since morning, I have been attending all other states' presentations. They were very good. Especially congratulations, Dr. Manjusha and the entire Hyderabad team. You have been pushing us to do something, and we are. And Dr. Saivani and Dr. Jikki madam, they are taking active part. We are just listening, and yeah. So all the best to everybody. Thank you.
I especially have to thank Dr. Saivani for keeping me in touch with all the activities down and doing good groundwork. And Dr. Hitashi and all the other members who have supported the AP program. And it was I personally feel, not to boast of ourselves, this is a very excellent program. And congratulate all the speakers. And then thank all the chairpersons who had been kind enough to join the sessions. And of course, Dr. Urmila Anand and Dr. Manjusha, what great work that you have done. And of course, there's one more session of Central Zone also to, Central Zone, or I think West Zone to go on. Central Zone, sorry, to go on.
Madam, thank you. Thank you so much. I think the WIN India keeps going because of the immense support that we get from the WIN state chapters.
The state chapter secretaries and presidents are very active. I can say proactive. You can see your state people too are truly proactive. The young generation is truly very active, madam. So that's how we are, and we are able to keep. We are able to go in a prospective manner, madam. So I think it's all a team effort that's been coming up. So of course we have been having programs since morning, and all the programs have been going excellently well, including the one, the WIN AP. We have the simultaneous session which is going on for the WIN Kerala, which is continuing. And as madam said, WIN Central Zone is the one which is pending, which will start at around 8 o'clock. So request everybody to join for the sessions, and your support. I'm just wordless and speechless for the immense support that we get. Unless you support us, we cannot go. Since the inception of the state chapters is the first time that we have invited all the state chapters on a single platform. And thanks to the tech personnel as well as the state chapters representatives, that is been going on, touchwood, without any glitch. So thank you everyone, and thank you so much. Over to Kirti for further proceedings and closure.
I would like to extend my heartfelt thanks to each and every one of you for joining us for this important webinar. We are grateful to our distinguished speakers and chairpersons for sharing their views on this critical topic, hoping this message helps us in our efforts to better kidney health. We would like to express our appreciation to all the participants who took their time out and made this webinar interesting. I would also thank the organizers who worked for and brought this webinar to life. We appreciate your hard work and dedication in making this event possible. Let us strive to ensure access to high quality kidney care, regardless of the socioeconomic status, gender, and geographic location. Once again, thank you for your participation in this webinar. Thank you.
Thank you all. Thank you, Jikki madam, Hitaishi madam, and all the seniors, and Chakravarti sir, Venu sir, and Nehru sir, who accepted the chairpersons, and Manjusha madam, who guided me in making this program. Thank you.
లేదమ్మా మీరు జాయిన్ అవ్వలేదని అదే కాల్ చేశాను.
And I thank all the speakers who accepted and willing to participate in this program. So if nothing is there, we will end up the session. Thank you. Kirti? Madam? Madam?
Yeah.
Okay.
Good night to all of you.
Right. Okay.
Bye, madam. Thank you, madam. Good night, madam.
Good night, Amma.
Bye, ma'am.